Again, we looked at the outcome, and I will skip through this in the interest of time to say that those who participated in the in-course project, they did just as well or better than any of these registration trials where people come for study, for follow-up, and if you don't see them 15 minutes ahead of time, you call a taxi and send it for them. We treated 106 to 1 between January 2003 and 2008, and those for whom we had complete data. When we compared the end of treatment result and the SVR result, the bottom line is we had very satisfactory outcome. The bad, we're swamped, probably a victim of our own success. We spend lots of our time wasting, I shouldn't say wasting, but doing the paperwork and that type of stuff, and that detracts from the work that we're supposed to do. There are some who are very special needs, and then some who are high needs. They just walk into the office, and we just have to deal with them. The ugly, we still have lack of funding. As the years go by, from year to year, we don't know if the program can continue, because from year to year we have to apply for grant funding. There's stovepipe funding. There are agencies that have work, but regardless of the funding that they have and wherever they have it, the inmates are not going to go there. But if you say channel some of the funding to where the inmates will come, you don't get that fund. I used to belong to the university. I say I used to because I found it to be a waste of time. I used to be on the faculty for the UBC, Department of Healthcare and Epidemiology. Through that mechanism, I was able to apply for some funding. About 4 years ago, we applied for another grant funding for the same project. It took about 6 to 9 months for them to process the funding that came through. Never alerted us that the funding had been finally ready to be accessed. Then, when we wanted to pay our nurse, we sent them the invoice. They promptly informed us that you can't access the fund because after 1 year it goes into general revenue. There was the salary for one outreach person buried in the bureaucracy of our tertiary care university. I think that some of these are challenges that we have to address. And in conclusion, when we look at the in-course project, I think that the prison definitely offers a setting where we can do good medicine, we can practice good public health, and we're in a very good arena for ensuring that once care is initiated, it can be completed in the community. And we should treat, because once we offer treatment for these diseases, we can reach a vulnerable population who is marginalized and who we tend to refer to as hard to reach. I say it's not a hard to reach, it just makes sense that if we go to the right place, we're going to reach them. I have to acknowledge the team who did this, who could, and continues to do it. And the reason I show this is because the team itself is very small. We have, because of lack of resources, we can't employ physicians. We currently have a nurse practitioner. The nurse has left. We have a nurse practitioner. We have 2 foreign medical graduates, and we have a real all-rounder who makes things happen. And this is our team. We need to continue, I think, encouraging efforts such as these rather than frustrating them. We need to work in the prison setting because close to 18% of all new documented admissions would have had a Hep C diagnosis in the community. During the same period, we know that about 9% to 10%, roughly 1,500 per year, are going to be released in the community. I show this picture because this is a guy I saw just 2 days ago. He went to the institution in June. last year, and was referred to me last month. I finally saw him yesterday, 2 days ago. He had a new set of tattoos. Unfortunately, he had it in the prison setting, and although he didn't stay there for a very long time, he acquired Hep C. About 10 to 15% of our hepatitis are acquired in the prison setting. It's about 10 to 15% of folks who have never started intravenous drug use are going to start when they get into the prison. They learn how to do drugs. I know my time is running short, but I'm going to deal with quickly some of the other issues and challenges as I see them. Normal ALT. Some of us know Kelly. Unfortunately, she passed away from Hep C a year ago. We may know of Teresa. Teresa, she had Hep C, normal ALTs, couldn't get funding because of the criteria set up by Pharmacare. For years, she was housebound. She was depressed. She loved dancing. She wouldn't go out because she was scared, or because of the stigma. She had some grandchildren, felt scared to deal with these to hug her grandchildren. Through a compassionate access program, we were able to get her the treatment. Ultimately, she responded satisfactorily, and now, one of the most shy ladies I've ever met, she's an advocate for getting out and treating. The unfortunate fact was she likely acquired it because she was doing some foster care. And one of the persons she was taking care of, there was some incident, and needle stick, blood splashing, and that's about the only risk factor we could come up with. When it was found out that she had hepatitis C, even the foster care work that she was doing, quotes work, that was taken away from her. She basically lost her house. She had no income. And she still is fighting to get some recognition of the fact that there should be some compensation. And this is what we're up against. Some of you may have remembered about 3 or 4 years ago, I'm always mouthing off something. There was an item that appeared in one of the newspapers about a sense of urgency for dealing with our hepatitis problem. We had a famous Minister of Health who basically, when he was asked about it, he says, you know, I think it's unfair that this doctor is saying we have an epidemic. You know, we did a study of those with normal ALTs. And again, to cut to the chase, what we found, after looking at over 500 patients, regardless of the level of the ALT, the people do just as well. Secondly, once the treatment is completed, the average ALT is between 20 and 30. In most of our labs, they have been set at 60. So for you to be qualified, found to be eligible for treatment, you have got to get a level of 90, when in fact your level is probably 15 or 16 if you're a female, and you're probably 20 or 30 if you're a male. We have been talking about this for the last 10, 15 years, yet nothing is done about it. I applied to Pharmacare. It was interesting that Wayne mentioned that there's nobody waiting for treatment. Well, in my practice, I've got a lot. Victoria must have something special, or they may have special a route to get into the channels of those who approve the treatment. We have had an approval rate of 78%, 599 over the last, I think, 5 to 6 years have been approved. We got a rejection rate of 28. That is despite the fact that we many times do not apply when we know they do not satisfy the eligibility criteria. We have about another 700 people waiting because we know that it's just going to be paperwork if we send this information in. A year later, we had a change of Minister of Health after the previous one. I've been through quite a few ministers of health. And again, some of you may have seen the item when he was asked about the problem we are facing with someone who was doing special things to get eligible. Basically, this guy was going on a drinking binge to get his ALTs elevated. He basically said, quotes, "I have better things to do than deal with this now," and talking to the CBC. So he's basically said, and again, it's an interview done on The Current where I participated, and he was there. He made the assertion, and I call it an assertion, that we have a committee of specialists who make decisions based on evidence. They don't want individual doctors to be making these basically cowboy decisions. Well, I ask, where is this BC specialist committee? I have been working on hepatitis for the last 12 years. I'm yet to be advised who are on this committee. How often do they meet? What are the criteria for getting on this committee? What supporting evidence do we have about the meetings, the numbers, the kinds, the requests adjudicated, and the outcomes of the adjudications? What supporting evidence do they have for their decisions? When was the last time the review committee approached pharmacare with regards to the eligibility criteria for treating chronic hepatitis C virus infection? Who does this committee work for? I would throw this out, and you go and ask. Our Minister of Health say we have a committee, and this committee deals with it. Let us know who this committee is. I'm going to skip over the next slides because this makes the point that whether we want to sweep it under the rug or not, it is costing our society when we ignore treating hepatitis C early. Rob published some work from Calgary where he's basically showing that over time, causes of hospitalization that are Hep C related continue to increase. We have to start doing those types of studies and start emphasizing them and reporting them. Our expert committee refused treatment on this lady who is lying right now on the Fraser Valley because her liver enzymes are normal. You see, Hep C is treated as a liver disease, not a systemic disease, but we in our practice know that the consequences of Hep C can be multi-systemic. This lady has renal failure, she gets infections, she has cryoglobulinemia, a condition where there's rashes on the feet, gets infected, she's in and out of the hospital. Whenever she's in interferon, she does well. Try and get her for the last year, some more interferon and the new current treatment, we can't get her. And our famous committee will not approve this treatment. You tell that to this guy. He unfortunately got Hep C, was treated for a brief while, got reinfected, applied for the treatment. Because he was reinfected, he was not afforded the treatment. The sad facts are that after he was diagnosed in an institution, on the day that his sentence finished, he was discharged like this. He ended up at the Royal Columbia Hospital with a tube in his belly, catheter. He spent about 6 weeks in the ICU. He is now basically doing nothing. We've applied for him for disability. He would not be treated because he got reinfected. Who is counting the costs of these decisions? You tell this guy that I need a committee who has never seen me. You tell the lady before that I need a committee rather than an individual physician to deal with my problem. Let us talk about it and see what we can do. But that's what obtains right now. I'm not going to go through the burden of hepatitis C. I just alert you to the point that I keep stressing in my clinic. I'm seeing a disproportionate number of people with cirrhosis. There are 13 over the last 10 years who have had liver failure, 3 who have had to be transplanted, 24 have had a liver cancer, and 21 have died. These are the stats that we need to get out. This is the face of the hepatitis, not those stats that we're seeing only this is what the rate and whatever rate, et cetera, et cetera. This is what's happening in my practice. Those patients are real patients. And I think that the challenge that we face is how do we communicate that to our funders? How do we communicate this to our payers? How do we communicate these facts, the face of hepatitis C? The reality of the hepatitis C we're facing, that if we don't deal with it now, we're going to pay later. I have about 10 other patients I plan to illustrate who had developed cancers, who died because of lack of initiating early treatment, but I don't have the time. But we have to have a mechanism whereby I think every time another person develops hepatitis C-related cancer, it should be making the news. Just like when there's a mad cow disease. Every time a person has a transplant, we should hear about it. We should hear about why is there a disproportionate amount of research and funding going to the few people who keep not responding to treatment, and we have 30 to 40% of people who we have ready access to that we are not devoting any time to reaching. Recognizing or shutting the fact that sooner or later it's going to come back to haunt us, because the vast majority of these people are going to be coming back in our community. I know I'm running out of time. I'm going to stop here and, because I can go on and on.
I'd like to have a seat. We can have questions. Okay. Now, isn't that incredible? It puts a face to a disease that we all have to really take a chance to look at. And I really applaud the enthusiasm and the frustration that Dr. Farley has. So, questions. One thing I would like to bring up just before we go further is there will be coffee and refreshments at the back. And also at the end of the day, there's a bag just by the door. If you could please leave your evaluations, your summative evaluations, so that we can get a sense of maybe in other sessions what types of topics that you would like to see presented. So, questions?
Just two quick questions. Is there any country in the world that's getting it right? And number two, have you asked your administrative person, the one that does everything for you, to send a letter for freedom of information to find out who is on this committee?
In terms of the countries that are doing it right, ironically, we in Canada are way ahead. So let's tell you what's going on. I think Australia is probably a close second. When it comes to helping, one of the slides that I have there, in fact I can get to it, was a petition that we have had going. We have about 800 signatures so far asking our ministry to review the policy with regards to the normal ALT and to make treatment available based on sound science rather than just a feeling. And I've got a few of those petitions in my bag, and I'm hoping that we can get that sent off to our ministry. One of the thoughts I had was to bring this issue up for our ombudsman to look into, but you're absolutely right. I think that one of the things maybe we might want to start looking at is through the freedom of information. Now the issue is that you have, and I really, again, I applaud the efforts of folks such as Fran in terms of bringing these issues to the forefront. But unfortunately, what tends to happen, and this is why, again, I really appreciate coming here, because we need to get other people involved. Every day that I don't go and see a clinic and have to go and apply for this and write for that, it takes away from seeing the patients. So there's so many things I wished I could do, but one of them that I hope that we can get on with was advocating for the ombudsman or somebody to look into this whole idea as to why and who makes the decision about who they're treated. And how come in every other disease other than hepatitis C, we can have a decision made by talking one-on-one to a physician, and in British Columbia, we can get away with a committee that just ticks on a little form based on 3 columns that are completed, whether a person can get treatment or not. Those issues need to be looked into. But I think many people don't know about it. Many people don't know that we have something called hospital privilege. I didn't get into that, but many of you have heard me talk about that. You're a physician, you belong to Region X, and that happens very often. You see patients from different parts of the province, different parts of where you work. In our wisdom, in Vancouver, our tertiary care hospitals, if you don't have so-called hospital privilege, I call that belong to the club, your patients cannot be seen for services there. Right now, we have patients who must travel for miles from one region to the next, simply because these hospitals will not do procedures like liver biopsies or blood transfusions in people who need them, simply because their doctors don't have so-called hospital privilege. We can do a liver transplant without a hospital privilege, but we cannot figure out how to get a liver biopsy done without hospital privilege. All of these add needless cost because you have to refer to somebody in the institution. It takes 3 to 6 months before they're seen. They basically rubber stamp what you've said. It takes time. It adds a humongous amount of cost to the system, duplicates services, and ultimately who is suffering is the patient. These are issues that are systemic that we need to look into. And I think that those are issues that need to be addressed by our hepatitis committee. Where's our hepatitis committee? I've been practicing for the last 15 years. Never have I been invited to say, let us participate. What's going on with hepatitis? Let's see how we can solve the problem in BC. You know? So we have to start getting out and holding the folks responsible. And I think we don't know enough of what's probably going on in our world, the sort of medical world, to be able to hold the feet to the fire of the so-called experts.
Dr. Farley, thank you. While you were waiting in the airport today, the airport lounge, you didn't hear that we actually had some good luck getting some answers from Pharmacare. We asked them about a month ago when they offered to take written questions and give written answers. We asked the questions, and then at 7 o'clock last night, they actually answered them. And they also offered to take questions from this group. So we'll start with yours. We'll send those in tonight, and maybe somebody else has more to add. But we did offer to take more. So.
Thank you.
Okay, any other questions? Okay, well, thank you so very much, Dr. Farley. It was a little bit of a challenge for you to get here, but thank you indeed.